reviewed in the Chapter 4 excerpt what other countries have done when they reformed their healthcare system, and now we're going to start talking about the U.S. The focus of reform conversations in the U.S., and we're going to look a little more closely at 4 of the major frameworks that have been a focus of legislative and policy conversation in the U.S., and those are summarized in Table 16.3. Managed competition, national health insurance, medical savings accounts, and individual mandates. And then we'll cap it off with some examples from state-based efforts at reform, because often states are good petri dishes for testing things out at the that will eventually be implemented at the national level. Well, what is the focus of reform? Well, spending is high in the U.S. In 2014, spending was $9,523 per person, or 17.5% of the gross domestic product. That's statistics from the Centers for Medicare and Medicaid Services. European countries, in contrast, typically spend 10 to 12% of GDP, and you've seen statistics like that flashed around quite a bit. There's a lot of that rhetoric is in the news. Some of the reasons for these high levels of spending are, well, if it's covered, if the person is covered, then you have the moral hazard effect influencing how much the individual chooses to consume, and you also have fee-for-service reimbursement to the providers, leading to highly specialized care because the providers get paid more for everything they do, and so they can focus on very intensive care. So there was historically not been any controls on the supply side or the demand side for reducing utilization. There's a use of emergency department as a safety net when people don't have coverage. It's a lot less efficient to go into an emergency department when your kid has an ear infection than it is to make a same-day appointment and go see your provider. There have been no limits on the use of technology, other than maybe an insurance company saying, no, that's still experimental. We won't cover it because it's experimental. But once it's FDA approved and part of the established practice, there's been no real limits on the use of technology. And also, you may not be aware of this, but our doctors are compensated a lot higher than doctors in other countries are compensated. So a physician here has a really nice lifestyle financially compared to physicians overseas. But that's not specific to the medical industry. That parallels high salaries for executives in other industries. For example, the extreme example is the CEOs, executives at the top of the pyramid. They make 400 times median employee salary in the US. In the UK, the ratio is more like 22 times median salary. I think in France it's 15. So in Europe, the multiple of median salary to CEO salary compensation is much more moderate than it is here. A much less extreme example is if you look at the ratio of the average salary to the 95th percentile salary. So not the extremes like CEOs, but just the average to the 95th percentile. And in the US, that ratio is a lot lower. You're dividing by a bigger number when you have that 95th percentile. Access to care is a significant problem in the US, and so that's been a focus of reform as well. So some of these cost control, getting rid of high levels of spending, but also access, getting people to insurance. And so most reform efforts actually focus on moving toward universal coverage. Our first framework that we're going to discuss is managed competition. And this framework is a blend of the structures in Switzerland and in Germany, because Germany talks about employment-based coverages and Switzerland talks about managed competition. And so this kind of is blended together. Usually in the context of conversations in the US, managed competition has been discussed in the context of employment-based coverages. Now, of course, because you are providing coverage through employment, that means employees pay through a reduced salary, right? Because total compensation stays fixed. If you're going to force some of that compensation into benefits, then you have to take away from pay. Managed competition keeps insurance private. There is not a government insurer, it's private insurers competing for employer groups and for the employees in those groups. Typically in managed competition, the crux of managed competition is that employers pay a fixed subsidy. Typically they'll pick, say, the cheapest plan and pay some fraction of the cheapest plan, and the employees will pay the difference between that fixed subsidy and the total cost of the plan they pick. So when I consider the difference between plan A and plan B, I pay some fraction of the cheaper plan plus all of the difference between the two. And that means that because I'm receiving all of the difference between the copayments when I seek care, I should pay all of the difference in premium from plan A to plan B. That's the philosophy behind managed competition. Typically in the conversation about managed competition, Medicare and Medicaid are preserved, and we're talking about just changing the way employment-based coverage is fixed and it is administered. Some of the criticisms about managed competition is forcing employers to provide coverage. That forces a huge fraction of low-wage worker compensation to be delivered in the form of benefits. So there's not a lot of their compensation left to be delivered in the form of take-home pay. And so that might be tough on low-wage workers. Could also lead to layoffs in that population, because if there's a minimum wage, so I can't shift from compensation because I'm already at the minimum wage, that means I just can't afford to hire as many workers, and so I may have to lay some off. Another way employers might get around increased benefit costs is shifting from full-time to part-time employees. So I may fire a couple of full-time employees and hire 4 part-time employees to replace them, because I'm only required to offer benefits to full-time employees. So those are some of the concerns that we see in this framework. National health insurance is similar to Canada. We talk about a single payer for all groups. Typically, when we talk about national insurance, we talk about funding it through income tax, possible also to fund it through a payroll tax. That's what some countries have done. With the national health insurance, one of the big advantages that they talk about is reduced administrative expenses, because you don't have all these different insurance companies replicating activities. You only have to install one claim system. You only have to have one set of contracts with providers, and so on. Some of the criticisms include the fact that there's no competition to spur efficiency. If you have 2 or 3 insurance companies competing, remember they can compete in a lot of ways, and one of the major costs going into the premium is the actual cost of paying claims. And if we can figure out ways to deliver care more efficiently, we can bring that cost down. And so some of the innovation that comes from competition would be lost with national health insurance. Also, there's some concern that a monopoly insurer, the government, wouldn't be responsive to consumer preferences. Because they are a monopoly, they don't have to respond to competition. Why should I care about this segment of consumers has a special need relative to the average? I may just peg everything at the average person in the country. And of course, national health insurance, if you put it in place, that would impact employment in the insurance and brokerage industries. We just talked about the fact that we're spending 17-point-something% of the GDP on healthcare. Well, a lot of that's infrastructure, and if we get rid of the infrastructure and replace it with national health insurance, then all of those people have lost their jobs. So that's one concern and a source of lobbying efforts against national health insurance. Medical savings accounts have also been talked about. This was the medical savings accounts that we've talked about. We called them healthcare savings accounts. Those were actually put in place under George Bush I. This is not an insurance scheme, although it is typically paired with a high deductible health plan. The savings account itself doesn't provide any insurance. Through a medical savings account, individuals use their personal contributions to the savings account to pay for routine care. They can also use their contributions to save for retirement coverage. all contributions to the medical savings accounts, or as we called them earlier, HSAs, are tax deductible. And the theory in this conversation, when people talk about this framework, they say that savings will replace Medicare. So if you start off with a medical savings account when you're first employed at 22 and you sock money away for the 40 years of your career, hopefully you'll have enough there to pay for your coverages after retirement. And so the theory was these medical savings accounts could be a replacement for Medicare. And that's usually the context in which they are discussed. They also are theoretically going to encourage efficiency through reduced moral hazard, because you're spending your own dime here. Instead of just having the insurance company pay, you're pulling your own money out of a medical savings account to pay for services. So it makes you stop and think a little more carefully about where I'm going to spend that dollar, and so that increases private competition. But of course, there's a lot of criticisms here because it's not insurance. It won't lead to universal coverage. All of those access issues that Dr. Nyman discussed aren't addressed with this. There are no reductions in administrative costs with the medical savings accounts. In fact, it creates a whole new infrastructure of administration. MSAs contradict the value-based insurance design research that shows that routine care should actually be the cheapest care because there's so much preventive care in routine care. And if we force people to pay for their own dime for routine care, but then have a high deductible health plan to pay for catastrophic care, you're saving dimes where you don't want to be saving them. Also, these medical savings accounts, they don't have controls for high-end costs like end-of-life care. People hit their out-of-pocket limits on their high deductible plans, and then they just spend what they want to spend. And so medical savings accounts don't address those issues and don't help us think about how to effectively deliver those really high-end costs. We also have a history with pension savings in the 401k plans that suggest that it's unlikely people will save enough to replace Medicare. So we're going to take something away. If we take away Medicare, we're going to take something away that people aren't going to be able to save for. And finally, the tax benefits are regressive. The contributions to the savings accounts are tax deductible, but of course low-income people don't even owe any tax. They don't make enough to owe tax, or if they do, their marginal tax rate's really low. Whereas somebody who's a high-wage worker, they're making $200,000 a year, they could have a marginal tax rate of 40% when you take state and federal and put it together. So they could be saving a lot with that tax break. The last one we want to talk about is individual mandates, and this is like Switzerland, where every individual is required to go out and buy coverage on their own. People are required to buy some minimum level of coverage. You have to buy a plan that it's at least this good. Tax credits are usually there to ensure affordability to help the low income. If through the imposition of individual mandates, we eliminate employment-based coverage, that could lead to a more efficient job market. I don't stay in a job I'm maybe not very well suited for just because I can't get rid of I don't want to lose my insurance. That's called job lock. If instead I have an individual mandate and I've got underwriting reforms and everything I need to be able to buy coverage on my own with tax credits to ensure affordability, then I won't need employment-based coverage anymore. And that means if I'm not well suited for a job, I don't have that locking me in, that need for insurance locking me into the job, and I could just go switch and find one that I'm better suited for. There are, of course, criticisms of individual mandates also. The market can be confusing. You've got all these individual insurers competing for your business. And so when we talk about the Affordable Care Act, we'll talk about some of the things that the Health Insurance Exchange is doing to help take care of that. There's no impact on moral hazard because you still have the insurance mechanism reducing the price for the individual, and so there's no utilization controls. So it doesn't do anything to create efficiencies. It just gets coverage in place. And some folks have argued that forcing individuals to purchase insurance limits individual freedoms. If they want to go bare and get sick and not have coverage, then they should have the right to do that. So that is one of the criticisms that's been leveled. Okay, let's talk about examples of state reform. Hawaii created an employer mandate. Boy, I couldn't tell you the exact year, but it was over a decade ago. They were able to do that because of their geographic isolation and had a very successful implementation. If we tried to do that in the contiguous 48 states, for example, if Minnesota passed employer mandated coverage and you had a manufacturer who was thinking about where to build their next plant, you can be sure that they would have built it in Wisconsin rather than Minnesota to avoid that employer mandate. Hawaii didn't have that problem. They're off in the middle of the Pacific, and so they were able to do that, and it was great. Maryland, their efforts focused on cost control rather than access to insurance. They've regulated hospital rates for years, since the 1980s, I believe. They've been very successful in containing inpatient costs. What they do is they require the hospitals to come in and negotiate rates and document why they need a rate increase every year. And then those rates apply to everybody, whether they're paying out of pocket or through private insurance or through federal insurance like Medicare and Medicaid. In Massachusetts, they had probably the most famous state reform effort because their reform efforts were the framework for the Affordable Care Act. Their reform included a combination of individual and employee mandates, employer mandates, excuse me. And Massachusetts was successful in moving toward universal coverage. Their uninsured rate dropped to about 4%. They have an unusually high number of physicians per capita, so there was no concern about, as people got coverage and everybody suddenly had access to coverage, are they going to flood the market and the doctors would be overwhelmed. There was similar conversation about that for the Affordable Care Act. We don't have the same level of physician per capita across the nation that Massachusetts had, but I'm not hearing a lot of policy conversation about that being a problem as the Affordable Care Act gets implemented. Vermont negotiated a single-payer healthcare system. That legislation passed in 2011, and it was going to be effective in 2017 under an Affordable Care Act exemption. So Vermont didn't have to build the networks, the health insurance exchanges, to deliver the individual mandate. They were going to have a single payer health system, and so people would purchase from that state insurer. Well, as this developed and the costs got priced out, it became clear that it was going to be a lot more expensive than they thought it was going to be. There were very high projected business taxes, and so that effort was shuttered through a legislative repeal in 2014. And that's the end of our chapter 16. So go on and listen to the very last video, the summary of the Affordable Care Act using the Kaiser Family Foundation summary.